lecture series. Or should I read? Okay, on behalf of the Texas Aging and Longevity Consortium, I would like to welcome you to the TALC Public Lecture Series. This event is sponsored through the generous support of St. David's Healthcare. My name is Yuanjing Zhou, and I'm assistant professor at the University of Texas at Austin, Steve Hicks School of Social Work. I'm currently working on developing fall prevention programs for people with dementia and their family and friends caregivers. As this is a public health priority around the globe, we are excited to be able to invite local and international speakers to share their innovative research and program efforts in addressing this critical gap in clinical practice and research. I'm one of the organizers for today's webinar, and I will be your moderator. So today's webinar will be recorded and shared with the wider public who are interested in this subject. It is my great pleasure to introduce our three speakers to you today. Our first speaker is Kristen Hallam, who is a trauma injury prevention coordinator at St. David's Round Rock Medical Center. Kristen Hallam has a master's in nursing and has been a registered nurse for St. David's Healthcare in Austin for over 20 years. In her many years working in critical care, she cared for many older adults who suffered injuries in the fall. For the last 8 years, she has been working in the trauma development department as the trauma injury prevention coordinator. In this role, one of her priorities is to provide fall prevention education to patients and out in the community. Our second speaker, Dr. Keith Hill, is the director of the Rehabilitation, Aging, and Independent Living Research Center at Monash University, Australia. Dr. Hill is a physiotherapist and a senior researcher with over 40 years clinical experiences in rehabilitation and aged care, and extensive track records in the community in implementing and completing a broad range of research programs for older people in the community, hospitals, and residential aged care settings. Keith has particular research expertise in areas of fall prevention, exercise, and aging well, has a strong focus on interdisciplinary research, and has research collaborators in Singapore, Thailand, Hong Kong, Malaysia, Canada, Sri Lanka, UK, and Brazil. Our third speaker is Dr. Claudia Mayer. Dr. Mayer is a senior research fellow with the Barton Clark Research Institute based in Melbourne. The institute is embedded with Barton Clark, Australia's largest independent non-for-profit aged care provider. She leads a program of work which implements research evidence into practice, combining research and physiotherapy skills across the spectrums in the community and the residential care for fall prevention and dementia care. She holds adjunct positions at the Monash University, Flinders University, and La Trobe University, and is current president of Australia Association of Gerontology. It was a great honor to have you three today. We will have Q&A after all the three presentations from all the audience. You may raise up your hand, unmute yourself, and ask questions at the end of all three presentations. Feel free to use the chat functions to pose your questions during the presentation. We will address as many questions as we can at the end of the presentations. Okay, let's welcome our first speaker, Kristen Hallam.
Let's see. Okay. Let me share my screen with you all. All right, can we see that okay? All right, well, as Wanjin said, I'm a nurse. I've been a nurse for a little over 20 years, and so I've had a lot of experience with fall patients with and without dementia. In the critical care setting where I worked, and then currently in our trauma department. And so I do work for a level 2 trauma center with St. David's that is here in the Austin area. And falls is actually our leading mechanism of injury, cause of injury at our trauma center, more than motor vehicle crashes or anything else. And I think that's pretty true for most trauma centers around our nation. And so our goal always when we discharge a patient after a fall is to make every attempt to help prevent a subsequent fall, but we know their risk is very high. And that really presents an extreme challenge, especially in those patients with dementia. And so, some of the facts here that you may already know, but of course, we have a growing older adult population, and there are many of those patients who have some form of dementia and a wide range of symptom severity there. There's lots and lots of research on effective and evidence-based fall prevention strategies, but not so specific to older adults with dementia. And so that is something that, hopefully is a growing area of research. And we can know that fall risk is for all older adults. There's many factors that can affect that, right? So vision, their weakness or their balance, their muscle strength, home safety, community safety, medications. But when you add that cognitive impairment that we see with dementia patients, then it can significantly increase that risk. And by some research here in the United States, it showed that about 50% of older adults with dementia experience a fall compared to closer to 28% in those without dementia. And those patients with dementia who do sustain a hospitalization are more likely to discharge to a facility of some type, whether it's temporary or permanent, rather than home, if home is where they came from. And so that last point for those of us in the hospital caring for these patients is really key, because this can be kind of a turning point for this patient and this family, not in a good way, where they may or may not even get to ever return home again, and life kind of isn't quite the same for them. And so our challenge is to ensure that we are working with them and their families to send them to a safe place, whether that is home or somebody else's home or a facility. And it's a challenge because many of dementia patients who, of course, like anybody else, we wouldn't want to leave our homes, but it presents another challenge for them because as they go somewhere else, it kind of can increase their confusion. Yet the level of care that is needed for them after their injury, especially physical care, may be more than what families are able to do. And so what kinds of challenges do we see in fall prevention? Well, for this population? Well, again, there's a wide range of symptom severity for patients with dementia. And so we try to assess that as best we can on admission, and then see how that has changed when it's time for discharge, if it has gotten better or worse, if they're kind of at the baseline that the family reports. What's their ability to perform their ADLs, their activities of daily living? This is huge because if they can dress themselves, feed themselves, bathe themselves, toilet themselves, then it's a lot safer for them to be able to go home with just that family member than it would be if they can't do that and there's not really anybody there to help them with those ADLs. And so we look very closely at what their abilities are to do that, not just from a cognitive standpoint, but now they might have an injury that makes it even more challenging for them physically. We tend to see a very rapid progression of muscle weakness and a deterioration of their balance. And, now that they've had, and of course, it always depends on what the injury is, right? Is this just a kind of a fracture to the arm, but their legs are still working? Was this a hip fracture or a femur fracture? So it kind of depends on what the mobility is for them after their injury. But if they are immobile for a period of time, it can be a real challenge to rehab them to the point where they can keep up with whatever mobility they had before they came in. Polypharmacy is the term that we use for multiple medications, usually about 4 or more medications. And this is a problem with all patients and all older adults, but even more so in those with dementia, because they may experience this magnified side effects, especially of confusion and irritability. They may be extra sensitive to sleep loss. We also see big problems when we have patients who come in with oral anticoagulation, so blood thinners. They may be on that for some type of comorbidity that they have. Sometimes it's due to the certain type of dementia that they have, in hopes that the blood thinners, so to speak, will kind of help perfuse their brain a little bit more. The challenge is that when they fall, it increases their likelihood of bleeding. And so we see so many patients who have fallen and hit their heads. There's really where the biggest problem is. And then we see that increased risk of bleeding both in the brain or in the subdural space around the brain. And this creates stroke-like symptoms. So not only do you have whatever level of dementia they already were at, you might have worsening confusion and then speech problems or physical weakness on one side or the other, all of those stroke symptoms that you can sort of imagine. And it can take quite a while for those to resolve, if in fact they do at all. We always educate the patients, of course, and their caregivers for fall prevention strategies, but can they remember them? Are they able and capable of putting those in place for themselves? Do they have the level of family involvement or caregiver involvement that would be able to help them if they were to go home again? Is that going to be enough, and is that going to be safe for them? And keeping in mind that a lot of times when we're talking about these older adult patients, the person that they live with, if they do live with anybody, is often an older adult spouse who may be experiencing cognitive or physical changes themselves. And so this can be a real hard thing for families and their adult children and whatnot to really kind of come to terms with and figure out how to deal with. And so if they are living alone, or even if they were living with somebody, what can we safely send them back to? Could they go live with an adult child? Could the adult child move in with them? Do they have the financial resources to be able to provide in-home caregiving? Or do we need to look at kind of that pit stop between the hospital and home of rehab or a skilled nursing facility until they can get that additional physical and occupational therapy that would be helpful to them until they get home? And then another real challenge is that the recovery after a fall or frankly, any medical event, we could be talking about a heart attack or anything else, but the recovery after the hospitalization for a patient with dementia can be much more lengthy and involved and challenging than it could be for someone without. And hospitalizations can, in fact, make their dementia presentation worse. We are constantly interrupting your sleep, right? With checking your vital signs every couple of hours or a neurological check. We are giving you sedation or anesthesia, especially if you needed surgery. And it can take a while for that to wear off for a patient who already has a cognitive issue. We are giving pain medication, and we have to be super cautious with that. We want to manage your pain, but we also know that side effect can really increase your confusion. And then you just had a general change in your surroundings, which can be very challenging for some of these patients who really rely on, the orientation aspect of being in that familiar place for them. So what do we do? How do we get them out into the community, hopefully in the safest way possible? And I will admit that it is an incredible challenge, because once they leave us, they're out in their community and their home, and we have minimal follow-up with them. And it's one of the aspects that I am trying to work on within our facility. That is, how can we follow our trauma fall patients and connect them with community health advocates and the support team, and ensure that they're following up with their primary care physicians. So we have very tight case management, both nurse case management and social work, that work together as a team to ensure that we get them to the safest place possible. We involve the caregivers at every stage, and we hope that we have caregivers that are able to help. It can be especially difficult when the caregivers themselves have their own personal barriers, and sometimes that happens. They have small children, or of course they work, or any number of things. We do provide both written and verbal education about the fall risk strategies, this kind of standard ones that and then we follow up with them to offer a class on this for both the patient and the caregivers after they have discharged. We encourage, even after discharge, physical therapy and occupational therapy and exercise programs to maintain that strength and help to increase their balance. But that can be a problem too, because Medicare only covers so many visits per year. And so we help them look for other ways. Are there community centers that offer Tai Chi? Are there, there's all kinds of other types of resources to help get them some movement. We encourage early use of assistive walking devices with the assessment and the education provided by a physical or occupational therapist. And we encourage them to look very closely at the nutrition. And sometimes I think family members don't really consider the effect that nutrition can have on their strength and how would that increase your fall risk. But if they're not eating well and they're not getting enough protein and they have muscle wasting because of that lack of protein, then they're going to lose muscle at a faster rate. And so we talk to them about how to get enough calories in them, how to supplement protein if needed. And that can be especially challenging with a patient with dementia who might be losing their appetite or even have swallowing difficulties. And then again, just trying to connect them with the community health advocates and a support team so that hopefully we don't get them back at a trauma center with another fall. So that is all I have.
Thank you so much, Kristen, for sharing your unique experiences about fall prevention for people with dementia as a healthcare providers in the hospital settings. We are going to hear from Dr. Hill next. Thank you.
Apologies. Can you hear me now?
Yes.
Just go to full screen. There's obviously a delay between Australia and where you are. So you've got me now? Yes? Okay. So I'm going to talk to you a bit about physical activity, mobility and safety for people with dementia. And a particular concept throughout what I'm talking about is changing the focus. I think what we're doing currently for people with dementia is not the right way to go in these particular domains. So the focus that I've got for this presentation will be on community setting. It's going to be reviewing some of the things around physical performance, falls risk impairments for people living with dementia, and do we assess these? And if we do, when do we assess these? And then look a little bit at the research evidence about, well, even if we do assess them, can we do something about them? So this slide is from the Australian Institute of Health and Welfare, and it shows a number of different domains where people with dementia can have problems. And
Excuse me, Dr. Hill, I don't think we are seeing the presentation. We are still on the first page.
I'm going to log out, not log out, but just stop screen sharing.
Yes.
And share again.
Sorry for interrupt.
That's okay. What slide are you on now?
We're still on the first slide. Do you have more than one screen open on your?
I do. Just hold on. Very sorry.
Totally fine.
now?
Looks like it's going through. Yeah, you're on your second slide now.
Okay, so what I was just mentioning was the issue of requiring assistance with mobility is one of the key areas. 80% of people with dementia through this national survey were identified as having problems with their mobility. So that's in the top part of the slide for community living and in the bottom part for shared care. You're okay now? Yep. So from what I want to look at now is what happens with the trajectory of cognitive decline and the health system focus from the first time where memory and cognition starts to decline. And it's not at that time that diagnosis happens. Diagnosis usually happens well beyond that, and often a number of years after the first signs are evident. And what we see is that there's a period of reduced cognition before that period of diagnosis of dementia. And for some people, this is a formal diagnosis that is made of mild cognitive impairment. And people with mild cognitive impairment is a very important time to try to get in and to look at what are the problems and what can be done. A moderate proportion of people with mild cognitive impairment do progress to having a diagnosis of dementia eventually. Some people actually stay with the diagnosis of MCI and don't change, and some actually reverse to having normal cognition. But at this time and around the time of diagnosis, the total focus pretty much is on cognition. It's on extensive neuropsychological assessments. And unfortunately, there's really very little systematic focus on physical performance assessment, falls risk, and those related things. So what I would suggest is that this is an important time because the same sort of changes do occur. I don't know what's happened to my slides, but I'm sorry. You should be seeing now a physical performance and a physical performance decline slide. So what my impression is that along that same trajectory of cognitive decline, physical performance is declining, falls risk is declining at the same sort of time. And again, what we see is that physical performance is not assessed routinely along that continuum, despite the fact that it is changing and it is declining. And the thing that often triggers someone getting into seeing a physiotherapist or an occupational therapist is a new acute event, something like a fall. Then a therapist may come in place and they may end up having an assessment. What I'd argue is that we need to change the focus and get in at that earlier stage and assess these things. Now, the next few slides just highlight to you some of the issues of older people with these problems, so people aged over 65, and also then thinking about people with dementia. So we know falls are a major problem for older people. 1 in 3 older people will fall in a 12-month period. For people with dementia, as Kristen said, around half will fall and in a 12-month period. And for some of the less common forms of dementia, up to 90% will fall in a 12-month period. So falls are a major problem. Not only do people with dementia fall more, they also fracture more. And this is a recent systematic review that highlights, compares just a small number of studies, but bone mineral density at the femoral neck, and shows a significant reduction for people with Alzheimer's disease versus those who don't have dementia. From a balance impairment and mobility impairment and also physical activity point of view, this slide shows you a 12-month longitudinal study of people with mild Alzheimer's disease. And on each of these parameters, you can see that there's already, with mild Alzheimer's disease, a moderate reduction in physical activity, timed up and go, and step test, and that there's a greater rate of decline over the next 12 months, around about 10% on each of these parameters. So people with dementia have already at mild stages got these moderate problems worse than the older person without dementia, and they're rapidly declining. So this slide just summarises all of that and just shows that these are big problems for older people generally, but they're even bigger problems for people with dementia. And yet this is what I think we do. This is certainly my impression of what happens in Australia. I'd be interested to hear of what the systematic approach is in Texas and more broadly in America. But I wouldn't be surprised if this imbalance in terms of what is the major focus at this time is similar. And it's unfortunate because we know, particularly with older people generally, that all of these physical things that I'm talking about, plus falls risk, are amenable to intervention. And so again, I think it's an important opportunity to think about changing the focus. We need to get a systematic approach to getting balanced mobility and falls risk assessments occurring early on in the memory cognition loss trajectory. So that's all well and good, but can we do anything to reduce these risks with older people with dementia? So one of the very common and most researched areas for older people generally without cognitive impairment to improve balance, mobility and falls risk is exercise. It's only in more recent years that we've received more research in this space. The earlier studies in falls risk and exercise all excluded people with dementia, which is a major problem. So you can't necessarily generalise from all of that data. But on this slide, I've pulled out a number of systematic reviews. Most of them a fairly small number of studies. I've divided them on the right-hand side of the slide into single modality, so just a balance training or a strength training type exercise. And on the left-hand side, multimodal, where you bring together a number of those different types of exercise. But importantly, they're all starting to show that we can improve function, reduce falls, improve strength and balance. So that's all great. But even more so, we're seeing that exercise can have a positive effect on cognition. So things like attention, executive function, and even in one of the randomized trials, one of the systematic reviews by Hager, we can see cerebral changes, increased hippocampal volume. So this is really a no-brainer. We need to be putting in place these sort of interventions. The other thing to keep in mind with these is that they have all been done with very low adverse events, so they're safe and they're feasible for people with dementia. They do need a bit of tailoring and a bit of modifying from what we would do with an older person without cognition in terms of instructions and in terms of the carer involvement often, which Kristen mentioned, can be very important. And so this is the most recent, one of the most recent systematic reviews, meta-analyses looking at falls and exercise. And now we've got 9 randomized controlled trials. I think 6 of those were in the last 5 or 6 years, so that this is very recent. And there is a significant 30% reduction in the rate of falls. That's comparable to what we can get for people without dementia with exercise. So important to be looking at this and starting early in the dementia trajectory with this sort of intervention. I must stress the importance of the care partner. A lot of these exercise studies involve the care partner as the person who will support participation, correct the application and the safety. It's the amount of exercise that's required is recommended to be at least 3 times a week. And that's often not able to be provided by a healthcare professional, but it can be provided in home practice. And so the important thing is how can the person with dementia do this safely at home? So usually that will involve the carer. In a few of the studies, and in one of the ones we did have a small number who were without a carer, and we were able to put in place a few strategies and modify the exercises a bit. But we also need to be very careful when we're asking care partners to actually participate in these sort of things, because care partners, particularly I'm thinking of older care partners, often have health problems of their own, and they're also very highly stressed. A benefit for some of them is to actually participate in the exercise program with the person with dementia, because that gives them a mode of exercise as well. And often they are not doing enough to look after their own health. But the stress and the burden of having the care partner actually supervise and perhaps nag the person with dementia to keep doing the exercise can be quite stressful. So we've got to monitor the care partner in this process. It won't be for everyone. But what we do know is that physical activity participation around the time of dementia diagnosis is low, and it does decline further over time. So it's not just a matter that the research shows this and it will happen, it's not happening. So how can we perhaps change that? One of the new trials that we're getting underway with, we've aiming for around November this year, is called Changing the Focus again, trying to get this physical activity intervention, a broad range of physical activity options in place for people with mild dementia who are not meeting physical activity guidelines. We've done a co-design phase to try and work out what is the best way to try to get this implemented and sustained participation. And the major focus of the interventions, not just saying, we've done an assessment, this is the exercise we think you need, and off you go and do it. But the assessment's only a small part of it. We're looking at shared decision-making, goal setting, access to relevant local physical activity options, and supporting the participant in this over time. They're not just sent off on their own. So this is a busy slide, but it just shows you in the second part of the assessment, the type of things we're looking at, shared decision-making as part of this, and then commencing the selected options and the supported follow-up over the next period of time. I do want to highlight the shared decision-making as a critical part of this. And what we'll be looking at there, as well as the assessment red flags, are what are the current activities, physical activities the person's doing that could be increased? What are previous activities that they enjoyed doing but they've stopped doing that we could resume? What are other activities they never thought of but they might like to try? Is there a preference for group or individual or community, and so on? We'll come up with a prioritised list of preferred potential activities from that shared discussion. We'll look at what is locally available, how to access it, transport cost funding schemes. These are all barriers that usually stop a person. So we'll be working with the person with dementia to come through this and then come up with a preferred set of physical activities and then that support over the next 6 months. So that's one thing we need to focus on. The other thing that I'll just highlight very briefly here is around what we call gait aids, what I think you'd call walking devices, and that whether this sort of approach is appropriate for people with dementia. Now, on the left-hand side here, older people who don't have any cognitive impairment, very routinely they will have if they do have a balance problem or falls, they'll have a balance assessment, they'll have an exercise program provided, and they will be considered for a walking aid, a gait aid. That might be with or without health professional advice. Many older people get a gait aid from another family member, from the pharmacist, and don't get any advice about the correct aid to use or how to use it. Contrast that with what we see often happens with people with dementia. There is that no routine assessment or screening at the time of diagnosis. Exercise is not part of what is routinely provided. And there's quite a lot of uncertainty about whether or not a gait aid should be used for these people. There's quite a bit of confusion. And part of that is around the fact that there's increased falls risk that has been reported in some studies associated with gait aid use. Gait aid use for people with dementia has been reported to increase risk. And so some people are saying, well, we shouldn't give anyone a gait aid who's got dementia. I'd argue very strongly that that's not the way to go. We need to look individually, and because those issues that I mentioned, that there's often no health professional assessment or advice, and the risk of using an incorrect aid, using incorrect height, incorrect method of use, all do increase the risk of falls. But if you can get all of those things right, often a gait aid will be helpful for the person. The other thing around how we usually apply a gait aid, it's usually if a person does get to see a health professional, it's usually a single assessment and a single decision yes, they can, or no, they can't. And we're usually a little bit risk averse. So if it doesn't look good, we won't recommend a gait aid. And it's often late in the dementia trajectory. So I've contrasted here routine practice on the left-hand side and a study that we've just recently published, which we called an extended gait aid training program. Instead of just hit and miss having a physio assessment, all of the people that we had 24 participants got a physio assessment, shared decision making about what gait aid to use, how they wanted to use the gait aid, etc. 4 physiotherapy home visits over 6 weeks, including exposure to different environments to make sure that it was going to be useful, or even sometimes 2 gait aids were useful, perhaps a stick inside, a walking frame outside. If considered safe with supervision over that 6 weeks, the care partner, the carer, was provided with training around supervising practice. So it wasn't just go and use it, but supervised practice before getting to full independent use. And then after 6 weeks, a final decision was made, gait aid or no gait aid, and 87% did achieve safe gait aid use. And there was also improved gait speed, step length and cadence at 6 weeks. So apologies for all of the technical problems, but the summary of what I've had to say is we need to do things differently. And some of these things are looking for opportunities to assess physical performance, physical activity, and falls risk for people with any level of cognitive impairment. We need to have shared decision making in the decisions around what interventions to put in place, and that includes the gait aids. We need to modify how we apply those interventions to the level of cognitive impairment and to the involvement of care partners where that's appropriate, and consider the health and wellbeing of care partners about whether they could also get some benefit from physical activity as well. And hopefully all of this will result in improved health and wellbeing of people living with dementia and their care partners. Thank you.
Thank you so much, Dr. Hill, for your wonderful overview about the fall prevention for people with dementia and your innovative work preventing falls for them, and also involving and supporting care partners. Our next speaker is Dr. Mayer.
Thank you. Okay, can you see my screen?
Yes.
Yep, correct. Thank you. Okay. Thank you very much for inviting me to present today. I'm going to speak a little bit more about the shared decision-making component of working with people with dementia in order to reduce falls risk and falls rates. So just to begin with, I work at Bolton Clark, as was introduced earlier, and I've been here for about 8 years. And we have a really long history of delivering nursing care in the community. We are a merged organisation of the Royal District Nursing Service in Melbourne with RSL Care in Queensland. We're the largest independent not-for-profit aged care provider in Australia, and we provide care across the full continuum, from home care through retirement living and into residential aged care. And that really helps to support the people in our care as their needs are changing over time. So I work in their research institute, and a really big focus of our work is moving research evidence into practice. So it's a pretty unique space that I sit in here. So I really wanted to focus this presentation around decision-making, because I think it's such a critical component in how we engage people with dementia and their carers in falls prevention strategies. So decision-making has been a shifting paradigm over the last few years. And for a while there, dementia fell between the cracks when it came to the protection of human rights. But since 2015, it has clearly come under the Convention on the Rights of Persons with Disabilities, And this is really, really powerful because we move away from a paternalistic, protective approach to a rights-based approach, which is around respect for a person's will and preferences. And that's, you know, regardless of their level of cognitive impairment. Now, substitute decision-making has been in place for quite some time, and it really does need to be questioned. It doesn't mean it gets tossed out completely, but it needs to be questioned, that one person makes a decision on behalf of another person broadly in that person's best interests. There's always room for a lot of conflicting views there. Whereas shared decision-making is along a spectrum, and it's supporting people with their decision-making. So where there's an intersection of their values, their preferences, and also the social supports that are in their life that can help them to make decisions. It is challenging, but it is really, really important, because to navigate the gradual but fluctuating journey of dementia, and hence their decision-making capacity. Decision-making capacity changes over time, and they may still be able to make decisions in some areas of their life, but not in all of them. So I'd like to share a couple of project examples with you. So I began delving deeply into shared decision-making during my PhD a few years ago. And Keith Hill, who spoke just before, he was one of my PhD supervisors. And it was a really great space for us to get into, taking our clinical backgrounds as physiotherapists, and also a really strong interest in moving evidence into practice, into this sphere of falls prevention for people with dementia. So as has been highlighted a couple of times already today, 30 to 40% of the older population in general have a fall each year, with 5 to 10% of those causing serious injury, fractures and head injuries. According to Australian data, for injuries that are caused by falls, for people over 65, that accounts for 60% of hospitalisations and 94% of deaths. And this figure continues to proportionally rise. As has also been mentioned, for people with dementia, these statistics are even more grim. 60 to 80% fall within a given year, depending on the type of dementia. They're at 3 times the risk of hip fracture and 5 times more likely to be institutionalised because of a fall. So, as all good PhD students do, I started with a systematic review. And we knew that there was evidence out there for falls prevention for the general older person population, even though falls rates weren't going down. But at the same time, at that stage, there wasn't a lot of work specifically in the space of people with dementia. In the last 5 years or so, that's changed quite a lot. But it became apparent quite quickly that the research questions that were being studied in kind of the quantitative space weren't always the questions that were important to the person with dementia and their carers. So I did a mixed methods review to try and tie together these two areas. Because if we want to successfully translate falls prevention knowledge, it needed to be relevant, pertinent, and meaningful. So health professional involvement, I mean, no surprises here really, but health professional involvement was found to be really important because people need help deciphering the evidence that's available. And it's our job to make that as user-friendly as possible and how it may benefit them. Inclusion of the caregiving dyad was also really important, as Keith mentioned in his presentation, because they're there to provide the necessary physical and emotional support. And there's an opportunity to work with the dyad, drawing on their really, really specific knowledge and expertise about their lives and on how we can make these strategies, falls prevention strategies, work best for them. And thirdly, accommodation of individual preferences with the right to be treated with respect and working with their existing capacities and their fluctuating capacities over time. So this was a really good starting point for how to work with this group. And from there, we developed a discussion tool. So we took the most common falls risk factors and collated evidence for what works, adding a dementia lens to it, and then working out the benefits and disadvantages of choosing a particular option. And finally, the context for the dyad needed to be established as well. We need to make sure we know what the functional capacity of the person is, the dementia severity, what levels of activity they're already undertaking, what their the carer self-efficacy and confidence is, what the burden levels is. All of those things are an important part of the context. And also by chatting with them, understanding what their perception of falls are, what meaning do they actually attribute to falls, is an important component. So this was an implementation study. It wasn't a randomized control trial. So I just need to pop that out there. But we used a validated falls risk assessment tool, and that was used to identify the high falls risk factors for someone. And this is important because we know that reducing the total amount of risk factors, any risk factors, can actually have an impact on someone's overall falls risk. So it was important to really tease out the high falls risk factors. And we also identified how ready they were to change behaviour for a particular risk factor. So drawing on the work of Prochaska's model, the stages of behaviour change, were they in pre-contemplation, completely unaware that they've got a problem related to falls, or are they denying that they've got any problem at all? Or are they more in the contemplation or preparation stages? They're beginning to acknowledge that there's an issue and they're preparing to make some changes, preparing for action. Or were they in action and they're actively making changes and sustaining those changes through to the maintenance stage? And that can vary according to what risk factor you're looking at. And this piece is also really important because if I come in as a physio, desperate to give them strength and balance exercises because I know that they're so good for people and we've got really strong evidence. But if that person hates exercising, then my strategy at that point is going to fail. And I really do need to look at what I'm giving them. And that's why discussing the options with them is so critical, because it's about giving them reasons to either choose or perhaps not choose that particular option at this point in time. So if I come back to the exercise example, as I said, there's plenty of evidence to support exercise, so that is a positive and a reason for them to take it up. But the downside is that it might cost them money to go to an exercise group. And if they are to exercise 3 times a week, that can add up beyond what they're capable of. They might need to arrange transport to get somewhere. That is a real barrier to people accessing exercise programs in the community. Or it might be that agitation is one of the behavioural symptoms that they experience, and is exercise actually stressing them and causing that agitation to worsen? So people need to know these risk factors and have a chance to work around them and have a choice in what they want to address first. So you might have a risk factor where the person has been losing weight, so the nutrition aspect of falls prevention is an issue. And it might be as simple as giving them some options around finger foods if they're not able to eat the food or cook the food that they were previously doing. It might be about having a look at their mealtime setup. So perhaps they're not eating because the crockery and the tablecloth is so busy with all patterns that they can't see the food on their plate and they lose interest and not eat. So this work really went into strategies in a very nuanced way. Behaviour change is hard though, and the literature tells us that most people don't take up recommendations. We're all the same. Every one of us, I'm sure, has an example of where we're supposed to be doing something and we don't. But through discussing the strategies, which tended to fall under referrals, resources, or advice and education, and then discussing how those strategies can actually be implemented in their life, in their context, the rate of adoption of the strategies was really high. It was over 80%. And it's about starting with the risk factors that they're willing to change, and then spending a bit more time gently talking about the others, giving them some time to digest the information and what it might involve. And then gradually, mostly, they will lean towards taking up one of the other strategies for another risk factor as well. So it's been a while since this work has been completed and it's not yet implemented. And that's because it's time consuming, it's resource intensive, and it's really messy work. It's a hard thing to bring into practice. But I haven't given up because I'm determined it's not going to end up like this in the chasm between research and practice. So at Bolton Clark, we now use a framework that's fit for purpose for our work, and it's been adapted from numerous other implementation models and frameworks. But what we've learned particularly is the massive piece of work around that socio-cultural political context. So it's the real world of health and aged care, because if I'm not acknowledging the environment of my organisation and the broader Australian health and aged care environment, then a program that I'm trying to bring into practice is going to fall over. And you need to be incredibly agile and prepared to keep changing it and changing direction, and gradually, incrementally over time, things change. The other important bit of this framework is co-design. Keith mentioned it in his presentation too. It's at the heart of what we do, because if we haven't had input from all of the stakeholders, everyone that's going to be involved, again, it's destined to fall over. And there are other really critical components. The first question of our 6 kind of questions going around is why? Why should people care about this? Why should they change? You might have the most fantastic tool or program, but if they're not on board with why you need to change, again, it's going to be hard work. So let me give you just another quick example as it relates to shared decision-making, again for falls prevention. So people with dementia may fall because they're taking risks. And negotiating risk is complex and it's often fraught. And on a daily basis, our frontline workers, and some of them I think are in the audience today, they need to balance up the duty of care that they have towards the older person and to potentially navigate the competing interests of family members, and then the right of the older person to actually take risks as well. This is constantly what they're doing. So we've developed a tool called Enabling Choices, and it was first in paper format and it's now been converted electronically, and it's been co-designed the whole way along with people with dementia, carers and staff. And it covers off on 12 areas of activities of daily living that are potentially risky or concerning. And for example, it may be that climbing stairs is becoming risky as the person with dementia is racing up the stairs 2 by 2. It may be that driving to their bowls club is becoming risky because they're not paying attention to the road rules as they're driving. It may be that completing their usual 5-kilometre walk is becoming risky because they're getting lost along the way. So we want people with dementia to stay physically active because that has huge implications for their falls risk. And this tool allows for a really gentle approach to have these difficult conversations. Behind these cards sit numerous options that allow people to continue their activities in a supported way. so that they get to explore the different components of these cards and then work out what strategy might suit them and how that's going to look. So maybe they get picked up by a friend to get to the bowls club. So they're still going and they're still being physically active, but they no longer have to drive to get there. It may be a technology device that's given to them that gives them directions for their walk, so they can still walk, but are not at risk of getting lost. Anything to keep them going with what they enjoy. But the challenge is getting a tool like this, again, into practice. And it's really best to start with why it's so important. We have the evidence through research that falls prevention strategies work. But in practice, a tool like this allows the conversation to happen. So rather than a health professional coming in to tell people what to do, it allows for this shared conversation to happen. It allows people to have a voice, to express their needs and their desires in a really safe and supportive environment. It allows frontline workers who might struggle with the complexity of this population to have some structure and some direction around these conversations. But also from a policy perspective, because organisations like Bolton Clark are always asked to show how they're meeting regulations, how they're meeting quality standards, how they're delivering person-centred care, and they're supporting dignity of risk. And a tool like this gives them the ability to do that. And just finally, the reason we're doing all of this is because we want to make a dent on reversing this trend. So despite all of the strong evidence that we have out there for falls prevention, over the past 10 to 15 years in Australia, and I'm sure it's the same in the United States, falls rates and hospitalisations related to injury are still climbing, regardless of everything that we're doing. So it really highlights to me why it's so critical to focus on implementing the best available evidence into practice. And at the heart of that is including people with dementia and their carers along that journey as to how it's going to work in the context of their lives. Thank you very much.
Well, thank you so much, Dr. Mayer, for your very insightful and innovative project. And thanks to each of you for your amazing presentations that you brought. And we were able to see a lot of practice and research innovations to prevent falls for people with dementia, and also the challenges to do this work and what we can do to go there. And today we have a wide audience, includes many service providers and community members who are living with memory loss or caring for someone who's living with memory loss. I would love to open up the floor to the audience to see if you have any questions or comments. Is anyone? You can just raise up your hand. Hey, Sarah.
Hi, I didn't raise my hand, so I'm breaking the rules, but I just wanted to say how exciting it is to hear what's going on in Australia. We get so US centric, I think, just speaking for myself, but there's so much overlap and we have a number of masters in social work students here a few of you in the room here, and it's really exciting for them to see the ways that you all are navigating care decisions and involving care partners, in this really important work. And so I just wanted to say thank you so much for sharing your knowledge today. I'm intrigued by Bolton Clark as an institution, and I'm kind of wondering, do we have anything like that here? Because it sounds pretty amazing. So just thank you so much for that. And yeah, it was great.
Thank you, Sarah. So Sarah Sword is the director of our GRACE program, which is a practicum program for social work working with older adults. So thank you so much for being here and your comments.
Thank you.
And why people are thinking about your questions, I want to attend to a few questions in the comments. Joan has a question about the percentage for the patient to go home and go to facilities. I believe that's a question directed to Kristen.
Mm-hmm. Yeah, so I'm not sure I can answer it with like precise accuracy, but sort of ballpark. I would say we send roughly 25%, 25-30% of our patients to some type of facility. Now, they may have come from a facility, so that could be already their residence. And when we say facility, there's a wide range, right? There's independent living, assistant living, or like nursing home. And so there are times when we might send them back if they're from independent living and they're lucky enough that their particular residence has a section that's assisted living. They may get to go there instead, or and see if they can get back to independent. The other thing is that some of them are just making that temporary stop to an inpatient rehab unit, which we have here at our hospital, but there are also facilities, locally that can provide inpatient rehab. And so that could be just a pit stop for them until they can get home. And then there's also an option if they cannot go to a facility, or maybe they don't quite need a facility at that, full level, that they can go home with home health. And we try really hard to make physical therapy a big piece of their home health intervention, so that they can get that same type of rehab at home, in addition to whatever, personal care or wound care or anything else. So that's kind of a ballpark answer.
Thank you so much, Kristen. You really highlight the complexities after fall happened and with all the transition care needs happening. And another questions, I think it's directed to Dr. Hill. And as you mentioned, there are different types of dementia. And Dr. Finkelman asked, are there some types of dementia that have greater risk of falls? And if so, are there different interventions that might need for people with different forms of dementia?
Yes. In one of the slides where I was having a little bit of trouble there, I did show that the most common types of dementia around about Alzheimer's and vascular dementia, about 50% fall. Dementia with Lewy bodies and Parkinson's disease dementia around about 80 to 90% fall. So there's differences in falls rates. Haven't seen much around the actual circumstances of the falls. From a exercise point of view, what we tend to do is to look at what are the presenting assessment findings, but also the circumstances of any falls that have occurred, because they do differ a little bit depending on the type of presentation, and that can be due to the type of dementia. If someone's always falling backwards, you'll throw something into the exercise program to try and attend that. If it's always on turning, again, that would be a bit of a focus of an exercise intervention. So to a degree, I wouldn't be looking at the type of dementia per se, but the presenting profile of both the falls circumstances and the assessment findings.
Thank you so much.
And I'll just add to that, if I can, that one of the things from more the medical side that we, not the PT side, that we try is to slow the progression of the symptoms with Parkinson's with some of those medications, some of those dopamine agonists that will help to reduce the tremors, or at least slow the progressions that they experience, with those gait changes.
Thank you, Kristen.
And I can also add just a little bit. I was giving an example for a different presentation the other day about a woman who had become a bit dehydrated, and she had a fall because of the dehydration. And it was going back to look at the reason why she was becoming dehydrated. And I think it taps into the different types of dementia. If you've got someone who's forgetting to drink because memory is one of their main symptoms, that's going to have a different strategy to someone who's lost the ability to plan the sequence, say, of making a cup of tea, because that's, that's been their main source of hydration. So I encourage our workers to think pretty carefully about why it's happened to begin with, and that the different types of dementia will have different impacts there.
Well, thank you so much for great insights from all of you and a great example. I think Liang Chen, I think you have a few very wonderful questions. Do you want to ask yourself?
Oh, yeah, sure. Thanks you for your sharing. And my first question would be, I love the idea of shared decision making, but I wonder how can we apply this idea to those population with the late stage dementia, and also their primary caregiver will not be their family member. So I think there will be a little bit challenging for the clinical practitioner to apply this idea to them. So I was wondering if you guys have a better idea for us. Thank you.
I can have a go at that one if you like. Yeah, it is challenging sometimes. You know, in the ideal situation, you've got two people living together and you can go and have that conversation together. But that's in an ideal world. Sometimes even when people are living together, the relationship is a bit fractured and that dynamic is difficult. So what we try to do is it's about having an open, gentle conversation, and it's not about trying to push our own professional leaning or bias onto them, but working out, you know, trying to get to the core of what their issue is. It might be about having a conversation with a carer separately as well, which I know our frontline staff often do. I've been in a situation too, you're in the person's home, you've tried to work together as much as possible, and then the carer walks you out to the car, and that's when you learn a lot more about the situation. So I'm not saying it's easy by any stretch of the imagination, but I think going in there with the idea that you're going to have an open conversation is a good starting point.
And I'll add a little bit to that as well, that you know, there's so many family dynamics that we see where you know, it's fabulous when there's a wonderful relationship between either the spouse and the patient or adult children and the patient, and nobody has any issue helping each other, but that is not always the case. And so especially if you have physical needs that need to be attended to and maybe there's not a spouse to help, then you have an adult child providing some personal care for their parent, whether that's bathing or toileting, and there's a real sometimes discomfort on both sides, and you're struggling, the patient is having this loss of independence, and that is a real challenge for those even without dementia, certainly, but those who have enough cognition to see what's happening to themselves can be so sad and so hard because they just have this loss of independence, and now they need help physically and they may need help with these decisions. And I think, like Dr. Mayer said, that it takes some compassion and some finesse and some understanding, you know, to have these kind of open conversations to address that vulnerability.
I think, hi, please go ahead. And Dominic, Mayor.
Hi. Sorry, I couldn't find the little icon to put my hand up. I just wanted to say, you know, this is just a fantastic presentation, but, you know, the element of time as well is really important. So, you know, in order to find out about their histories, find out about their interests, find out about their supports, you know, often we just don't have enough time to do that. But it is really important that, you know, as therapists and organisations, that particularly for dementia, and indeed all conditions, but dementia in particular, I think it's really important to try and devote that time for all of this that we're all speaking about. It's the only way we're going to find out. We can't just sort of go in and, you know, possibly, you know, being able to see the physical ability, you know, is achievable, but really finding out what underlies, you know, underneath all of that, and where the, you know, if behaviour change can occur, sort of where do they sit in that model is really important.
Yeah, thank you. We should all do more research to advocate more time to be dedicated to these kind of conversations. Along with the questions about engaging caregivers, and there's one question is about, is there any strategies for engaged caregivers in the shared decision making that you have tried?
Keith, yeah, you go ahead, talk, because I was going to mention the Changing the Focus project. You go, Keith.
Yes.
Well, I was going to say that we haven't got that project underway yet, so I'm sure there'll be some wonderful learnings from that. So I'd defer probably to Claudia with the work that she's done to date.
I think it's about trying to find common ground and a compromise. So, and as Dominique mentioned too, it's about having the time to find out what their interest areas are, what they've been doing, what they previously enjoyed, and that's the caregiver dynamic in that. Like how, I mean, most people are caregiving because they want to. There are some that feel like they have to. That is the case, but if we can focus on finding what we can keep the person with dementia independent with, as Kristen mentioned, then you're taking the pressure off the caregiver to do tasks that are not so favourable, allowing the caregiver to choose what tasks they do want to do, trying to bring in the help from outside. Our health systems are very different, but yeah, drawing on what funding mechanisms we do have. Yeah, it's challenging. Every situation is different. I think that's the hardest thing. So it's very difficult to say point blank.
Yes, I think when I'm doing research, what I heard from caregivers and service providers with people with dementia, every situation is different. How you want me to summarize? So thank you so much for the perspective. I think we have one more question actually related to the physical screening from Liang Chen that you mentioned about implementing rapid screening for frailty and sarcopenia in the community settings. Do you want to share your questions?
Oh, yeah, sure. So actually, I think I have a question for Dr. Hill about this. Is it feasible to apply this quick screening for the community-based residents instead of the single physical screening test? I think this might be like, is that what I want to hear your thoughts on you? Thank you.
Thank you. Yeah, there's so many things we could assess, and obviously frailty and sarcopenia are somewhat related to the issues and the domains that I've talked about assessing. My particular focus is on the falls prevention, and so the things that influence falls, and that's the balance in particular, is an important part. It's also an issue of time, as was mentioned earlier on, and how much you can assess. So you've really got to be pretty selective about what's the key things you want to look at for this particular person, and how can you do that in the most comprehensive way as quickly as possible with as little equipment as possible to make it practical and feasible in what is the clinical constraints of a person-client interaction. And so we tend to look mainly at a couple of tests, quick clinical tests of balanceability, and a couple of those I put on the slide, the step test and functional reach, a quick test of mobility, the timed up and go, a measure of physical activity level. So those would be the things that I would be putting in place for the type of things that I'm looking at. Strength is also critical, so 5 times sit to stand or something. All of this will help to inform the type of things you might want to put in place or discuss with the person with dementia and their care partner about the type of exercises or physical activity options that might be best for their particular physical impairments. But sarcopenia and frailty, you can take those in. And again, there's some fairly quick tools to assess those if that's your focus.
Thank you very much. I have a related questions. Do you have any follow-up questions? Okay, I just because that was so shocking, but also that's my experiences in the US as well. When people have MCI or dementia, a lot of focus is on the cognitive and neural test, and less of assessment and support the physio assessment. So in Australia, what might be the barriers for those kind of assessment to implement it, and how we can make this kind of assessment more accessible for people with with cognitive impairment?
I think it's just, to a degree, it's around how our system operates, and somehow you've got to just change that. And there are some glimmers where this is starting to happen. For example, one or two of our memory clinics, one in Tasmania, has started a trial where they're actually having a physio on board. Most of the CADMs and memory clinics here are all heavy on the neuropsychological, the geriatric, medical side of the staffing, and perhaps counselling and psychology support. But you won't see a physio or sometimes an occupational therapist, but there's not a focus on that at the time of diagnosis. And that's where I think there should be an attempt to have both the physical and the cognitive elements being assessed and intervened at that time.
Thank you so much for sharing that, or trying to continue working with the system using the framework that Dr. Mayer brought up. I want to go to another question for Kristen. You mentioned that the Medicare coverage may also play a role in fall preventions. Mm-hmm. Although Medicare mainly targets acute conditions, I was wondering, what do you think? What Medicare can do for long-term care, especially for people with dementia and the caregivers?
That is a loaded question, isn't it? What can Medicare do? So the bright side is that there is a lot of things that Medicare will cover for these patients. So they will cover cataract surgery, right? So if that's their issue, as vision begins to fail, when their cataracts get into a certain percentage, they'll cover that. They will cover assistive devices, canes, walkers, even wheelchairs, if you get to that point, if it's medically necessary. And so you need a physician or a provider's prescription for that, which really wouldn't be hard to get, right? As long as you're under the care of a healthcare provider, which is another reason to not just have somebody else, borrowing a walker or whatnot, but to go ahead and get that physician order so that you can get that covered. What I would like to see is Medicare focus more on these fall prevention strategies, specifically around physical therapy, because, for the most part, it will kind of only cover, I'm not the Medicare expert, but I believe it's around 20 visits a year, something in that ballpark, which is nothing for some of these patients, right? I mean, they'll do 20 visits in a month or 6 weeks if they're going 3 times a week. So, I would like to see them approve more of that. They do, I will say, Medicare covers, I think they call it silver sneakers, which may or may not be available to people depending on where they live. There's lots of availability if you're here in the Austin area, but they will cover a gym membership so that these patients can go and participate in some of those classes. It just may or may not be appropriate for the dementia patient. Right. So I think there's always more that Medicare could do, with the idea that it is cheaper and better for the patient to cover these prevention strategies than it is to pay for their inpatient hip surgery and subsequent stay in rehab and all that comes with that.
Thank you for saying out loud. Probably everyone in the room knows, but it's really important. That's why we are doing this work, preventative care for them. Thank you. I will see. Kelly Stephen also has a questions about the shared decision-making tool. Is this typically completed over a number of visits? Who complete the tools? I imagine it could be overwhelming to complete it on one visit.
Yeah, absolutely. It is designed to be an ongoing tool that's used as the needs of someone changes. So generally, I'm recommending that people take about an hour. You might get through 1 or 2 topics in that time, but that's probably as far as you're going to get. It's not specifically designed for preventing falls. There's just a lot of things in that tool that are relevant to falls prevention as well. But it's really designed to whatever's coming up for the person with dementia or their carer or the staff who are going in to see them. Yeah, so definitely not all in one. And we've had conversations with our frontline workers as to the best time to use it. And right at the beginning is not the right time either, because you've got to do that full assessment, get to know the person, and then it can get used over time.
Is there a specific professionals to complete the tools with the client and the carers? Who would that be professional? Like, is there a social worker or nurses or what specific professions?
Yeah, it's for our nurses and our allied health professionals. So we at Allied Health, we have physios, occupational therapists and social workers, all of whom could use the tool. It's probably not relevant for our personal care workers to use it. It's more for the other staff.
Hey, thank you. That's all the consideration you have to consider when you want to develop and use the tool, implement tool in the service settings. Do I have a social worker? Do I have an OT who can help me with that? So thank you. I saw we have another questions from Amelia. And do you want to share your questions?
Yeah, I can ask my question out loud. Thank you. This has been such an informative presentation, and I'm a social work student, so I really like the focus on systematic solutions and, you know, being client-centered. And Dr. Joe and I talk a lot about like the anxiety and fear that comes, you know, with falls. And I'm curious with the conversation tool, the discussion tool that you're working or that you research, Claudia, like how can we use this without creating more anxiety in care partners and in people with dementia? And like, how can we also convince and encourage them to know that focusing on fall prevention is really important to quality of life? Big questions.
Yeah, really good question. Yeah, I think about having the conversation is designed to be positive. It's not designed to highlight everything that's going wrong. It's hopefully picking up on something that is becoming a bit of a worry or a bit of a concern, and working through strategies that are going to support that, keeping the person with dementia as independent as possible, having them involved in making those decisions. So it comes back to and totally accept that it takes time. And this is why it's been so hard to implement it into practice, because to try and fit it into existing funding models is challenging. I know your Medicare system has its challenges, and so does ours, absolutely. Yeah, so I guess it comes back to how you have that conversation again with people. So that's part of the training of staff in using the tool, and it's called enabling choices. Like, it's to enable people, it's to support people, and just gradually over time you work through it. And I hope that momentum is then created, that they feel like they've achieved something by having this oh yeah, I can still do that, I just have to do it in a slightly different way. And then that encourages them to have the next conversation, hopefully reducing anxiety along the way. But yeah, great question. Thank you.
If I can just add to that, if there's people who have been in falls prevention for 10 or 15 years, you might have come across a little bit of a fad or a phase coming out of the UK, which was around don't use the F word, don't talk about falls, because it gives a very negative stereotype and it will increase fear and so on. Now, while that's true to a degree, you've got to talk about falls in my mind, and it's around positive framing of the message, and it will be different for each person or each dyad that you're working with, but you need to talk about falls in the context of independence and function and the things that you can do to minimize the risk of that fall. And the fall might be a small part, or it might be a big part of how you have that conversation. But you've got to be sensitive to the dynamics of that dyad and adjust accordingly, because for some people, it will be fear-inducing. For others, it's going to be motivating. And so it's really, again, unfortunately, all of this is tailoring to situations to get the best outcome. But yeah, it's a very, very important consideration, because that fear can become a major barrier to and a major factor in decline over time if it's not picked up and addressed. But it does often respond with exercise.
I sort of find that there's, I mean, we just meet people of either extreme, right? There are people who have had falls and been lucky enough to not have an injury with it, so they're very aware of it. They are fearful of falling, which again, you know, like you said, we're not really wanting fear. We're wanting to empower you and have you learn all these strategies to give you that independence and help you overcome those fears. But I see so many people when I go into community centers or churches or anywhere where we're trying to teach fall prevention, where they're actually not afraid because they just think it's not going to happen to them. Or if they fall, they're not going to have a severe injury. And I can't tell you how many times I have somebody say, oh, I'll just be more careful. I'll just watch where I'm going. And so then unfortunately, we don't really get their attention until they're in our emergency room and they see the ramifications of a fall, and then we're sending them home and now they're listening, and hopefully it's been a minor enough injury that they still get all these opportunities to make these changes. But I see both sides of it, and it's hard.
I'm so impressed with this panel. Let me say that I direct the Texas Aging and Longevity Consortium. Dr. Zhu spoke to me months ago about this idea that she researches, and I thought that the community would be very excited. I can tell you, I personally was very excited by this. This is not my area of study, and I learned so much about the idea. I've not thought about the physical components of dementia, and y'all brought that to my attention. I don't think that often about how you get people to change and get them to want to change, which you've all brought up, and get them to get the context and who else has to be involved in it. And I love the very individual approach. Someone else mentioned that. As a researcher, at least the way I've thought is, let's get a program. And what you're saying is really, okay, you have your program, but you have to bring this person on board. You have to meet them where they are. You have to ask what they want. You have to, because you're not going to get it from saying, here's my lovely program and everybody come and do it. And I love that. I thought you really made me think. I think I might be speaking on behalf of a lot of people in this group. And I just want to thank you all. And I want to thank everyone who attended and your great questions, and particularly to thank you, Wanjin, for just having this phenomenal event for all of us. So thank you, everyone. And we will be having a recording available if you want to share it with, friends, family, other people who are interested. And I'll let you, Wanjin, I don't know if you want to say anything more, but I'll pass it back to you.
Yeah, I'm sure a lot of people would like to talk and asking questions. Me, I want to ask questions and talk. But so thank you so much for being here. And I will definitely need to rewatch these recordings and listen to your feedback and experiences again. And thanks to the technology that we were able to cross the ocean and share our experiences So thank you so much. And thank you for everyone who take your afternoon times to join this talk. We're looking forward to provide more useful informations and programs in the future and for the community. Thank you.
Thanks, everyone. Bye.
Bye. Thank you.